Hello everyone, and welcome to Your Health, Your Choice. I am Dr. Roopnarine, and we are coming to you live from our studios at ACTN. On tonight's program, we'll be discussing various topics in the field of urology. With me in studio tonight is Dr. Satyendra Persaud. Dr. Persaud is a consultant urologist at the San Fernando General Hospital. Dr. Persaud is also present with offices in the SurgiMed Clinic in San Fernando. As usual tonight, our numbers should come up at the bottom of your screens, and we'll do our very best to get to your questions and comments in the final segment of the program. So guys, let's get the show going. Let's talk urology, and let's say hello to Dr. Persaud. Doc, how are you doing?
Robin, nice to be here.
Good. Glad to have you on the show, Sati. Very glad to have you on the show. So, Sati, the purpose of me having this show is that obviously in general practice we see a lot of urological complaints, people coming with different problems. Now, we can't discuss the whole topic in urology, so I just want to touch on a few important topics, right, that might be very relevant to our viewers at home. One of the most common things that presents into general practice is urinary tract infections and or kidney infections. So I'd really like you tonight to just discuss that a bit, especially if you could give some advice to those patients at home who may have recurrent infections in the urinary tract, if you could give them some advice. I would also want to discuss later on kidney stones, right? Renal calculi, as they call them in medicine, because a lot of our patients in Trinidad suffer from kidney stones.
Yes, very common.
And if you could just give them some guidance, explain what happens, explain the different treatments that are available in Trinidad for kidney stones, right? And if we have time later on in the show, I just want to discuss an important topic as well, which is erectile dysfunction.
Absolutely.
All right, Sati, so that's just the kind of structure that we're going to run with tonight. And let's start off with the first one being first, that is urinary tract infections, right? So, Sati, if you could just give us a little outline or a little description of what is urinary tract infections, how they come about, and how you evaluate it as a clinician and how you treat it.
So the urinary tract goes kidney, then there are two pipes that come down to the bladder, and then from the bladder, draining out to the outside, there's another pipe, which the structure is different. Up to the bladder is the same for men and women, and then after the bladder, it differs between men and women. Men have a prostate. The women's pipe going from the bladder to the outside is a lot shorter.
Yes.
So that predisposes them more to urinary tract infections. So the infection just simply means that there's some sort of bug in the body, most commonly bacteria, that actually invades into the body and causes symptoms. It causes a response by the body as the body tries to clear it and so on. You get fever. The more common symptoms, I mean, UTIs are very common in women especially. Right. Because their urinary tract, the tube is much shorter than in a man. Okay. And, you know, they get burning with urination. They want to go. They feel like it's very distressing because they feel like they want to pee every 5 minutes. Yes. And nothing is coming. That's just because the bladder is so inflamed. And you can have infection going all the way from bottom to the top. Okay. So with the infections in the bladder, they get this pain just below the belly button. Yeah. They might get cloudy urine. They might get burning. They want to go, what we call frequency, meaning they have to go. They get urgency, like they can't hold the urine. Yeah. They feel they have to go right now or else they're going to wet themselves. Yes. They might get fever if it's very severe. Right. Or they might actually smell the urine smells. Very strong. Urine smells very strong. Right. And then I think it's also important because as I realized this week, sometimes some people with a urinary tract infection don't have any of those symptoms at all. Like I find that in my practice, sometimes I see a lot of older patients. Yes. And I find like a lot of the older patients will sometimes come in with different symptoms. They might come in with chills, feeling cold. Yep. Sometimes they might be confused. And that's a very astute observation because especially there are populations that are different from so what I'm describing to you is the typical patient, right? Yes. But there are populations that are different. The spinal cord injured patients, yes. The older patients. Sometimes the sign of a UTI in an older man is just confusion. Exactly. Right? Exactly. They might not get fever. So the diabetic, the patient who's immunocompromised, they don't manifest the typical manifestation of a UTI. Right. So that patient might just might not get fever. They might get some pain. Yeah. They might get confusion. Yeah. You might smell the urine smelling funny when you go to change the pampers or so on. Right. So all these things are warning signs to look out. When the infection starts to go up now, so you go from the bladder up the kidney pipes into the kidney, they start to get back pain. Right. That's called pyelonephritis. Right. So I think it was important just to describe those symptoms so people at home could recognize what symptoms, the whole gauntlet of symptoms. So a patient has these symptoms, Sati, and they come in to see you as a doctor. What's the next step? So once you actually get that history out of a patient, you think they have a UTI. The next step is always an examination.
Yeah.
So you want to examine that patient from head to toe. You want to check the vital signs, make sure they don't have a fever, check their pulse, and then you go on to an examination of the tummy. Make sure they don't have any pain in the flank, in the belly. And then you might want to do some blood tests and some urine tests.
All right. So why is it? All right. So those are the symptoms. You know, it's a bacteria that causes it. But why do patients get it? Why does this bacteria find itself in the urinary tract?
So some of these bacteria actually, you know, the bacteria themselves are actually pathogenic in that they attach to the lining of the inside of the bladder. For instance, E. coli. You got little fronds on them, if you look at it, and they just attach on there. And some of the therapies are directed towards these fronds.
Okay.
Right? Some women are just predisposed to it, so it might run in family. So you find a mother who has recurrent UTIs might have a daughter who has a higher likelihood of getting recurrent UTIs.
Right.
UTI being urinary tract infection. Some women find that after intercourse, they have that. And if they use diaphragms or spermicide. And then there's this subgroup of postmenopausal women. Now remember, the vagina is normally moist and it has helpful bacteria in it. After menopause and the vagina dries up because of lack of estrogen, is replaced. There's no longer the protective effect of that good bacteria, and your more harmful bacteria can proliferate.
Right. And all right, so go on. So the patient comes into you, they have all the symptoms, the burning and so on. What happens next?
So after we've examined them,
I think, Josh, if you have any of these slides there to put up, you could put it up for the viewers at home to have a look at.
After we've examined them, we would normally at least do a dipstick. So what you're looking at there on the screen is actually the bacteria going into the cell. So it doesn't just go into the cell and that's it. It goes into the cell, it multiplies, and in some cases it forms colonies in the cell. And because everything's close together, and the man, that tract there between the bladder and the outside is actually much longer. So they tend not to get infections in healthy young men as much as healthy young women. But coming back to how we would investigate them, you have what you call a dipstick urinalysis, which is an easy test. I'm sure you do it frequently in your office. You just dip the urine and it's a colored strip, and you compare it. And you're looking for certain chemicals. You're looking for nitrites in the urine, leukocytes, or blood. And we can tell from that there is a suspicion. But before we start treatment, we always like to send off a sample to the lab. So the technicians will actually try to grow the bacteria from the urine and see what's resistant to or what's sensitive to. So we know which antibiotics to start them on.
And what else do you do?
We would sometimes, if
you treat it blindly all the time because the patient might be in pain.
If the patient is in pain, we would just start antibiotics. But we send off that urine culture, so in case our antibiotic doesn't work, we know now what we can treat them with.
All right. So I think it's very important that point that you made, because the patients at home need to know why we do a urine culture. And the purpose of the urine culture basically is to move away from blind treatment and to really focus the treatment on the particular bug that might be infected.
But your point is very valid as well. I mean, these patients are coming in, they're very distressed. Right? They're getting burning when they pass urine. They're getting pain. You know, they might have fever. So you have to start something. It takes about 4 or 5 days to get back a urine culture. So we generally start with a couple of different antibiotics, depending on what we think it is. And then if that doesn't work, then we have the urine culture to tailor our treatment to. All
right. So, well, let's just tell the public, what antibiotics would you use for urinary tract infection? You could just tell them the different classes.
So there are a number of different classes. There are penicillin-type antibiotics. There's the fluoroquinolones. There's antibiotics like Septra that we use, Septrin. Or nitrofurantoin. I find that right now we find a lot of resistance to fluoroquinolones. This is things like ciprofloxacin or fluoxacin.
Okay, so if a patient comes into you, Sati, this is for the benefit probably of some of my GP colleagues and myself. What do you think is the best antibiotic to give a patient with a urinary tract infection blindly treating?
I would usually start with Septra, or if it's a cystitis, I would give something like Uvamin, like nitrofurantoin. Now, nitrofurantoin doesn't penetrate the kidney very well. So
and these are different antibiotics that you use. Sorry, in case some of our viewers got lost there, these are different names or different antibiotics that we use for urinary tract infections. Sorry, go on.
So I wouldn't use nitrofurantoin for a kidney infection, but for a bladder infection, it works very well.
All right. Now, Trinidad, we have a culture sometimes that patients might be sick and unwell at home. Why is it important that patients get treated I tend to tell patients that a kidney infection or urinary tract infection, I want to see in the office right away. It's not something that you can delay and stay home with. Why is it? What is the dangers with a urinary tract infection when it gets bad?
So we have a lot of patients with non-communicable diseases, like diabetes, right? And
in Trinidad, yes.
Correct. And they have, they're relatively immunocompromised. And when they stay home with these infections, that can actually spread. So you can have a bacterial infection going from the blood and something that you can treat with antibiotics for a few days that goes to the kidney. And then it gets worse. And then it forms an abscess. So the downstream effects of them ignoring this is actually, they're not good. You can have a lot of potential complications.
They could get a kidney infection.
They could get a kidney infection or worse, a kidney abscess.
Right. What happens to a patient that has a kidney infection or a kidney abscess? I mean, it's not something that really treated in general practice so much. We tend to refer them to the hospital. What do you do in the hospital for those type of patients?
So it's not unreasonable if you think somebody has a pyelonephritis and they're not very, very sick to treat them as a GP, right? But if you've tried, especially if you've tried an oral antibiotic, and that means by mouth, and it's not working, then that person is obviously going to need some form of therapy intravenously. So we would send off the cultures. We would start them on IV antibiotics. And we would get some form of imaging.
Right.
Especially if they don't settle within 72 hours. You have to make sure they don't have an abscess. Now, an abscess is just a collection of pus in the kidneys. Everything coalesces, it forms a collection of pus in the kidney. So that's how we do it. And if we find an abscess, then we would just manage it.
Okay. So my point being to the public at large is that urinary tract infections tend to need to be treated and not sat on or not try something at home and see if it goes away, because kidney infections, or which is called pyelonephritis, could be very, very severe. And in my experience, especially with older people, these kidney infections, I mean, patients go very sick very quickly with pyelonephritis, and they certainly don't want they don't want them to be down for a very long time as well, because sometimes it could take up to several weeks to completely clear up a pyelonephritis and or abscess, and then they have to be in hospital.
It's funny I mentioned this. You mentioned this because there's a lady that I just treated. She has stones. And stones, there's a cycle. Stones cause infections, infections cause stones. Which we'll talk about later. She has these few non-obstructing stones in her kidney. And she came in last week, blood pressure 90 on 60. And
she got sick.
White cell count, and she has a pyelonephritis because of untreated kidney stones. And she's now better because we have her on culture-directed antibiotics. And 6 days later, she came today for follow-up, and she asked me why I'm so weak. Why do I feel so weak? It feels terrible afterwards. It'll take a few weeks for you to really feel better.
Exactly. So again, in the older population, kidney infections and urinary tract infections are nothing to play with.
Correct.
You have to be on top of it. All right. So you've given the patient some antibiotics now, Sati, and they begin to feel better. What happens next? You just leave them home, or you bring them back in, or what's the next step in the treatment?
We usually follow up. If they're not better in 72 hours, then we need some form of imaging to make sure we don't have an abscess. So a couple of reasons why you might not get better. We don't have the right antibiotic. Or we're missing an abscess. Right? There's something else going on. So we get imaging, we get urine culture. If they're feeling better, we continue a full course. And I tell people, don't stop your antibiotics. We did a study, and a lot of people are actually...
We did a study where?
In San Fernando. Looking at antibiotic practices.
All right, so tell us a little bit about that.
So we looked at about 200 men. In the 200 men and women.
This is in urology department.
In urology department.
In San Fernando.
In San Fernando. And I can't remember the exact numbers.
That's fine.
But you find a significant number of people are actually stopping the antibiotic courses prematurely. So they would have been written. So you're written for antibiotics for a reason for 7 to 10 days because you need this to completely eradicate the bacteria. They're stopping it once they feel better in 4 days. What that does is it just encourages resistance. And
repeated infections.
Correct. Or some of them are even giving it to their friends. Here, try this antibiotic. That's a no-no.
Did you have any more slides that you wanted to put up for urinary tract infections, or that was it?
No, that's okay.
All right.
I think we covered
so
most.
The next question I have to ask you, which is the most important question. We have people at home or people who come into my clinic and go, Robin, I keep getting these infections. They get repeat, and it's very frustrating because they live in their life and they have repeated urinary tract infections. What advice can you give to these patients, or how could they, what's your suggestion to them?
So, a repeat, by definition, there's actually a definition of a repeat infection. So the repeat infections are more than 3 in a year or more than 2 in 6 months, by definition. So that is what it's defined as. And when you have a repeat infection, you've either not eradicated the bug or you have something that prevents you from that causes you to get infections all the time.
Right.
Now we're looking at there is how to prevent a urinary tract infection.
Can you go through that slide with us one time? Because
Now there are a lot of things that we tell patients.
Yeah.
Drink lots of water, try not to hold your urine,
Yeah.
wipe from front to back, take showers and not baths.
Yes.
Right? None of this is really grounded in science.
Okay.
Right? The way I look at it is that it's not harmful.
Yeah.
So I tell them they can try that anyway.
Yeah.
Some people tell them to shave.
Yeah.
None of that is grounded in science.
But certainly not drinking enough water wouldn't predispose you to infections.
It predisposes you to kidney stones.
Okay.
You know?
Okay. So why do some patients, I'm asking you, why do some patients get repeat infections?
So there are different subgroups.
And what could they do?
So men get infections all the time because they have enlarged prostates.
Yeah.
And they're retaining the urine. And imagine having some urine stuck in your bladder there and you're not emptying it.
Right.
There's a good chance it becomes infected.
Right.
Then there are the patients that have some kind of obstruction to the urinary tract, like
Right.
a stone, or they have something in the urinary tract that, like a diverticulum or
All
something.
right. So what I'm getting from you here, Sati, is that once somebody has repeated urinary tract infections, it's all about investigating further.
Investigating further.
All right. And the investigation further is what? Ultrasound, CT scan, what is it?
We usually get an ultrasound. For men, we'll get a PSA for them as
Right,
well.
right.
And then the other group that gets recurrent infections is the postmenopausal women.
Right.
And that's important to recognize, to examine them,
Right.
to see if they have that kind of vaginal dryness and so on, because
Right.
we can treat it.
Right.
And some of these treatments are like a magic bullet for recurrent infections.
All right. So we have structural things like stones, problems with the big prostate that cause repeated infections, and then we have hormonal stuff in the postmenopausal women.
Some men might need a cystoscopy where we look into the bladder to see if there's anything in the bladder, anything abnormal. But especially as a man having recurrent infections, he's going to need further investigation.
Okay. All right, Sati. So that's great. You pushed through the topic very quickly there. We're going to take a little break, a little 2-minute break, and then we'll come back. And when we come back, we'll talk about kidney stones. All right, guys. So we're here with Dr. Satyendra Persaud. He's a consultant urologist. I want to encourage you to please send in your comments and your questions for Dr. Persaud in urology, and you'll answer it. So, guys, we're going to take a 1-minute break, and we'll be right back.
Football 101 is on every Tuesday and Thursday nights at 9 p.m.
I'm your host, Josh Rudy Matos, and I'm joined by Nikolai Madry, Jeremy Bridgenat, and David Lucky.
This is where you'll get all the football news that you need to know.
Glamorize football to what it is. The viewership speaks for itself at the end of the day. These guys are making billions on viewership.
With heated banter,
They'll have more trophies, more Premier League trophies, more
You are
Champions League trophies
talking
than
past.
Chelsea.
You are talking past. I'm talking about current situation of the club.
and trending discussions.
Barcelona was built around Messi.
But Messi created the most chances against Real Madrid in the Champions League.
Covering all the major leagues.
If you all don't win Europa, you can hold this. This is the only cup you all are going to hold.
Failure to support their core coaches with the kind of budget.
I think you have somebody delivering some food for you. We need to get service like this on the show.
Yeah, I can do some of that right now. It's about that time.
Football 101, bringing the field to your home.
You have the most assists right now.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
All right, right, guys, welcome back. We're here with Dr. Satyendra Persaud, and we're talking about urology, and we're talking about renal stones or kidney stones, a very common problem in Trinidad and Tobago. So, Sati, tell us a little bit about kidney stones. It's a very common problem. We see a lot of patients coming in. It's very distressing and a lot of pain. Sometimes it takes a while to solve the problem. Tell us a bit about it. Why do we have more patients with kidney stones in Trinidad than in other countries?
The answer to that is I don't know.
Right.
Because we don't have any research to prove it.
Right.
My anecdotal answer to that, having worked in
many countries.
In Guyana, Barbados, and Jamaica, and Trinidad.
Yes, and England.
For sure. And England.
Yeah.
For sure. We do have more patients with kidney stones.
Right.
Especially in South Trinidad.
Right.
You know.
Why do you think that is?
I don't know. Part of it is genetic, I suspect.
Yeah.
There's a slide there looking at multiple factors that cause. So this one here. So there's individual factors, family history, ethnicity, age, gender.
Yeah.
You know, and then there's the lifestyle and related factors, diet and dehydration, obesity. Like I said earlier, we have a lot of non-communicable diseases. We have an obese population that's Indian, and you know, we have a hot climate, right?
Yes.
And I suspect we have a genetic influence as well.
Right.
So the people who are out on the street, who are actually the CPAP workers, the people who are actually doing in the sun,
yeah.
you know, those are the people who are, you know, especially prone to it.
To dehydration.
Yeah, we'll talk about the role of diet a little bit later on. We eat very badly over here.
So those people that work in the sun in Trinidad, like in the heat, they get dehydrated a lot more quickly, and that will predispose them to kidney stones, correct? And that's something very interesting because I think a lot of the medical issues that we see in general practice, even the mild symptoms like weakness, fatigue, not feeling well, you know, a lot of those symptoms could be related back to early dehydration or mild to moderate dehydration. Trinidad is a hot place, and maybe less so now, but unlike other countries where, like in the United States, when I went on holiday, they see everybody walking around like big glasses, big bottles of water. Wherever they go, they just pumping water. It wasn't really our culture in Trinidad for many years. Maybe recently now it's improved, but that has highlighted to me the fact that, listen, you know, people are dehydrated. We need to push water.
Yeah, and you know why? Because what happens is you have all these salts dissolved in your urine.
Salts.
All these different salts. So, you know, calcium, uric acid, and so on.
Yes.
If you drink a lot of water, you keep those salts in solution. When your urine starts to become concentrated, either too much salt or too little water.
Yes.
Then these salts precipitate out of solution.
Okay.
And so you have too much calcium, you know, not dissolving enough or not enough water to dilute it.
Right.
They precipitate out of solution and you form these stones.
Right. And
so that's why water is important.
Right. And well, tell us a little bit about how the patient presents, what symptoms they have, and what do you do for them as a urologist, as a consultant urologist? What do you do for these patients when they come into uni hospital?
So, the most common thing is pain. Kidney stone pain is very, is very pain. Take it from me, as a urologist, I had a 2 millimeter stone. Now that's very tiny, 2 millimeter stone, and that was very, very painful.
Yes.
And you know, the pain is in the back, and it can come around the front. And as the stone moves, the pain moves.
I think any doctor who's worked in the ActnTheVoice emergency or in urology could kind of tell without even talking to a patient who has a kidney stone. Because you see them on the camera, or you see them in the waiting room, and they're like this, and they're pacing up and down.
Yeah.
You know?
So I tell patients all the time that, you know, back pain from working, from overwork, it's a different type of pain. You can alleviate that pain by standing still.
Yeah.
Kidney stone pain, there's no resting position. The patient is rolling, as you said.
Yes.
They're holding the back, and they're just walking
pacing up and down,
and they're stomping on the ground, and you know, they might be vomiting as well.
Yeah.
If the stone becomes infected, you can have fever.
Yeah.
And then sometimes when the stone is just about to pass, the pain moves down into the tummy.
Yeah.
And then when it's just at the bladder, they feel like they want to pass urine every few minutes, and nothing's coming. That's called strangury.
Okay.
So they just get that sensation to pee all the time.
Right. So this is what we have here on this picture there.
So this is how a stone begins, right? So this is called a Randall's plaque. Now it's more complicated than this, but it's just a bit of calcification on the inside of the kidney.
Right.
And this is where if you take a stone, you look at it under a microscope, you see like a little belly button on that stone. It's called umbilicus, from where it attaches to the inside. So sometimes you'll go in a kidney for surgery and you'll see these little plaques, and those are the beginnings of kidney stones. And if you don't take heed and you don't drink your liquids and you don't follow the dietary guidelines, those develop into stones.
Right. Right. So these patients in lots of pain, they come in to see you. How do you help them?
So we start off with, as usual, a history and a physical examination, make sure we're not missing anything, make sure the patient doesn't have fever. And then the next thing we do is try to get rid of that pain. The best medicine is the class of drugs we call NSAIDs, which is something like diclofenac or meloxicam or Celebrex, something along those lines. And that helps with the pain. It might need something as strong as morphine sometimes.
Right.
And then when the patient the pain is eased, we'll send that patient for confirmatory testing. Usually the best investigation for the stones are CT scans.
Okay.
So we'll send the patient for a CT scan, possibly an X-ray as well.
How about ultrasound?
Ultrasound is good if that's what you have, right? It's a good screening tool. But if you want really great information on a stone that really guides treatment, the thing to do is a CT scan.
Okay, go on from there.
So what we do after that now, we'll check the urine, make sure there's no signs of an infection.
Correct.
We'll check the blood test to make sure there's no sign of an infection. Check the kidney function test.
Because they could get infections with their kidneys.
Absolutely, they come in with fever, and sometimes the stone blocks. Remember, there's a slide up here with
here we go. These are tests.
These are the tests
which
we do.
you went through.
These are general tests for kidney stones, right?
Right.
But I want you to go to the slide with anatomy.
Josh, if you have this slide with the picture.
With the anatomy, because it's important to know the anatomy before we talk about kidney stones and how to treat it. So if you go there's a slide there with two kidneys coming down. This is where you peel. There we go.
Right.
So this is you have two kidneys coming down to what we call the ureters, and then in the bladder.
Yes.
When you have the stones in the kidneys, that's going to hurt in the back. As it starts to move down the ureter, which are the two tubes, it can block the flow of urine.
Right.
And then you have urine, stale urine there, and person might be diabetic, they end up with an infection.
Right.
And that could be a problem. You have to relieve that obstruction before you can even treat them. So that's why the CT scan is important. That's why it's important to really get a good history, do your examination, get your correct test done.
Right. Let's talk about a little bit about the treatments, right? What non-surgical options are there for our patients with kidney stones in terms of treatment?
So first of all, if the person has a small kidney stone coming down the tube, which is the ureters that we just showed there, if they have a small kidney stone coming down the tube and they're not in pain or they don't have any fever or they don't have any renal damage, we can watch them and allow them to pass the stone.
Right. So you just tell the patient what? Drink loads of water at home?
Drinking loads of water is not always helpful. Sometimes it causes more pain. What we do
why
is...
would drinking water cause more pain?
Because you have this obstruction and you're drinking water and you're filling it up.
Okay, it's like a blocked canal.
Correct. Right? So the kidney becomes swollen.
But in a small one that is not obstructing anything?
I tell them stay well hydrated. Okay. I don't force feed them water.
Okay.
But what we...
And no beers or anything like that? I mean, people in Trinidad...
That is actually very common. People say a hot beer.
Yeah. What do you think
I don't advocate drinking alcohol for your kidney stones. I don't know if it will hurt, but there's no benefit. There's no proof that beer is any better than water.
Okay. Might make you feel better.
It might make you forget about your kidney stone. But by small, I mean less than a centimeter.
Yeah.
So a stone less than a centimeter.
Yeah.
Those are the stones. Stones larger than a centimeter are probably not going to pass.
Yeah.
So a stone that's 5 centimeters has about a 60% chance of passing.
How about these tablets, like people say like Roatinex and Racol, which is tablets like mixed with olive oil and different types of oils, which people say will dissolve stones. Do they work?
So the fact that we do so much stone surgery, and I have a waiting list that's probably stretching into the years now in the hospital. And everybody's on Roatinex because everybody tells them take it.
Yeah.
I don't doubt that it might work for a few people, but by and large, I don't have any evidence that Roatinex or cystone. Cystone is the other one.
Yeah.
That cystone works. What does help with passing the ureteric stone, though, is a thing called, a class of drugs called alpha blockers.
Right.
So men use it for the prostate, and it relaxes the prostate, helps you to pee.
Right.
You can do the same thing with a kidney stone.
Okay.
So if it's in that tube, it relaxes the tube and it increases the chance of passing the stone by about 30%.
That's
so
good enough.
It lets the stone come out.
All right. So that's the non-surgical approaches to a very tiny stone in someone's ureter. What if the stone is not small, if it's a bigger stone?
Yeah.
What do we do then? Because a lot of people have bigger stones.
Yeah. So we have different, fortunately in Trinidad, we have all the options for kidney stones.
Okay.
Right?
In the public sector as well?
In the public sector.
Okay.
San Fernando Hospital has all the options for kidney stones.
All right.
Might be challenging now in times of COVID, but we do have all the options.
Okay.
So first of all, there's a thing called ESWL, which is extracorporeal shockwave lithotripsy.
Okay.
Now they put this machine on you, and they're guided by either ultrasound or X-rays, and the machine shoots out these shock waves, and it breaks the stone up. So this is a picture of it here. So you have a stone in the kidney, you put the patient on the machine, The machine shoots out these shockwaves. There's no cut on the skin. It breaks the stone up, and you pee the fragments out.
Okay.
Now, that's not suitable for everyone. Right. Common sense will tell you if if you have a big patient, the waves are going to become attenuated. If the stone is too hard, the waves are going to become attenuated. And if the stone is too big, we don't use as well. But it's a useful option for treating smaller stones under like 1.5 centimeters.
So obese patients is not going to work.
It's not going to be helpful as it would in a thinner person because all this bulk attenuates or blocks out the shock waves. The other option that we have is ureteroscopy.
Right. What is that?
So we pass a tiny camera.
I think you have a slide on that as well.
We do have a slide on that.
Josh,
I think it's after this. So this is going up. If you remember the anatomy, ureteroscopy just means camera going up the ureter. So we have rigid versions and we have a flexible version. And we pass this camera, there's no cut on the skin. We pass this camera up through the tubes into the kidney or into the urine pipe, and we can actually look at the stone and laser the stone and break it up. So there are a number of
via the instrument.
Via the instrument. So we can actually look at this thing and break it up, and we can take small stones out through with baskets. So there's another slide there.
Patient's urethra.
Yeah, this is going through the patient's urethra. There's a slide before and after laser ureteroscopy. So I'll show you an example of what I mean. So this is an actual patient that I did a few weeks back.
Let's describe it there.
That blue thing you're seeing on the left of the screen is the laser fiber. So we're looking head on at a stone.
Right.
And that's an 8mm stone. It looks big because it's magnified. And we have excellent scopes now. So these are disposable scopes. Use them once and you throw them away.
Wow.
This is an 8mm stone, and that's before to the left, and then after we've broken it up on the right. Now, I didn't take any of these fragments out. These fragments, they might look large, but if you think that this is an 8mm stone, those fragments are all 1mm or less.
So they're small enough to pass
They're small enough to pass on their own, and this gentleman actually sent me his x-ray 2 days ago. He's completely stone-free.
Oh, wow. That's great.
So if you go to the next slide as well. So if I've taken the liberty.
This is the same patient?
This is a different patient. Okay. This is a much bigger stone. This is about 1.2 centimeters. It's highlighted there by the red arrow. And we've actually done ureteroscopy, lasered that stone, and you can see on the right, the stone is no longer there. So it's a very efficacious option, meaning it works very well because we can actually see the stone and break it up. The third option that we have.
Before you go to the third option, sorry. So the laser part, is it a one-off treatment, or the patient you have to go back in? Would you go back in to remove the stone, or do you keep going back in?
No, so our goal is to remove as much as we can the first time.
Right.
But sometimes you can't help it if you have fragments.
Right.
So I tell patients
that you didn't expect, that you thought would have passed.
That you thought would have passed, or the fragments just escape because there might be a little bit of blood and you don't see that fragment.
Right.
So there's always a risk that you have fragments, but our goal is to remove as much as possible.
All right. And patients under general or local anesthesia?
Oh, general anesthesia. General anesthesia. They're asleep. It's actually a very well tolerated procedure.
Okay. And I suppose you do that. They do that in outpatients as well, in the private clinics as well.
Yeah, in the private.
And the patient goes home the next day or the same day?
They go home if it's done early enough in the day. They can go home the same day.
Okay.
Sometimes you keep them overnight just for observation.
All right. Cool. So you can go on again.
So the third option is something called PCNL. Now I say patients should not be getting cut for kidney stones these days unless in very specific circumstances.
Okay.
So what we do with PCNL, we actually put the patient is asleep and we put a wire into the kidney using an ultrasound. And then over that wire.
That's it there, that's percutaneous nephrolectotomy.
Over that wire, we open a tract. And through that tract, the tract is about maybe a quarter of an inch, a half an inch. And through that tract, we pass instruments. Now this person is looking at it through a camera, looking at the eye, but we're actually looking at it through the scope, using just their eyes, but we actually have a camera, so we're not actually doing that. We have a camera, we're seeing it on a big screen.
Right.
And then we can use the laser, we can use any other instrument, break the stones up and take them out. So the patient can have a stone that's 2-3 centimeters removed through, before it used to have to be a cut.
Yes.
Now it's removed through a tiny cut, about a little stab incision, about half an inch if so much.
Right. Right.
And this actually is used for bigger stones.
Okay.
So where a stone is 2.5 centimeters or 3 centimeters, and it might be a bit much to laser,
yes,
we can use PCNL successfully.
Okay.
We've taken out, I didn't include it on this slide presentation, but we've done complete staghorn stones.
Right.
A staghorn stone is one that takes up almost the entire kidney. And we've done that and removed all or most of it using PCNL. Okay. In rare circumstances, you might require a cut on the skin.
All right. Are there any other treatments for kidney stones?
right now in Trinidad, those you can treat most of your stones using one of those. It all depends on the nature of the stone and the nature of the patient.
Right.
For instance, if you have a patient who, you know, every patient is different, right?
Of course.
So if you have a patient who is anticoagulated, they're on Plavix and Xarelto, these are blood thinners.
Yeah.
Now we can't put a hole in the back to take the stone out or give them a cut. Laser is a better option. If you have a big patient with a hard stone, laser might be better rather than doing as well a shockwave lithotripsy.
All right, Sati. So I think we'll take a little break now as well. All right. So guys, we're here with Dr. Satyendra Persaud, and we're talking about kidney stones. So we're going to have a 1-minute break, and when we come back, we'll talk a little bit more about renal stones and a little bit about erectile dysfunction. I just want to ask you to please go ahead and send in your questions, should you have any, for Dr. Persaud. All right, so we'll be back in 1 minute.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest.
Welcome to Harvest. We're doing it double again, north and south. This morning we start here in Brazil Village on Bethany Estate with Michael and Jacinta Mill.
You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance.
So Wendy, you're about to show me your bromeliad house.
Yes.
Oh, this is lovely.
This is what our customers refer to as the Mecca for bromeliads.
Explore the many ways to make your harvest right for you.
So our chicken coop is more or less built at a height whereby it's easy for us to go and just remove the wood shavings into our barrow.
Now, you don't plant out your seedlings, you buy the seedlings, right?
Yes, we purchase our seedlings.
Here we are on a not quite monocrop site, but we have rows of tomatoes, rows of sweet peppers, and then you have the Milnes polyculturing.
Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're here with Dr. Satyendra Persaud, and we're talking about kidney stones. So, Doc, Josh, I think we have a WhatsApp message coming in. We'll take 1 or 2 messages.
Yeah.
Yeah, no problem. Who are most prone to kidney stones?
The research, people who are, as we spoke about out there, the people who are out there in the sun, who are not drinking enough, myself included.
Myself as well.
You know how it is. We see patients and we're taking up all day, and we drink 1 cup of coffee in the morning. We don't drink anything till the evening. That's bad, right?
4 or 5 cups of coffee, and the bottle of water is sitting on your desk, and you didn't even drink it.
Correct.
You know what I mean?
So we find in Trinidad that East Indians tend to have a higher prevalence, right?
Yeah.
People who are out in the sun, a lot whose job takes them out there, they can't get a drink or they're chronically dehydrated. People with chronic health conditions like obesity or even diabetes are prone. All this makes for very acidic urine. It's like a metabolic acidosis.
Right.
Where the urine is very acidic.
Right. All right. Any other question there, Josh? Anything else? No? All right. All right. Are there any non-invasive treatments for kidney stones?
Yeah, we spoke about that. So ureteroscopy is invasive in a way. PCNL, you actually do have to make a cut, albeit a small one. The non-invasive option is the shockwave.
Shockwave.
Shockwave lithotripsy,
All right.
or as well.
In terms of the causes of kidney stones, one of the things you told me about was diet. Diet is a big cause.
Diet is a huge thing.
Yeah.
People ask all the time what we can do to prevent kidney stones. Remember, if you have a kidney stone now, you have a 50% chance in 5 to 10 years of forming another stone. So one of the best things we can do for ourselves is actually diet. And the most important thing is liquids, and not beer.
All right. I think Josh have a next question that you want us to take. Josh? Can certain materials, and we'll get back to that afterwards, can certain materials or styles of underwear also irritate and increase the chances of getting UTIs in women and men?
So remember, this is one of the things we put up on there, and we said we advise people all the time not to wear tight underwear.
Okay.
Right? So we advise them to wear cotton underwear or loose-fitting underwear if they have recurrent infections. There is nothing to support that really in the evidence, right? So this is one of those bits of advice that I've passed down.
Yeah.
But there's not really nothing much to support it.
You know, Doc, I see a lot of kids. I used to have a small pediatric practice, but I used to have a bigger one before. And UTIs in kids were also quite common in the practice. What particular reason you would say that kids get urinary tract infections?
A lot of them, I don't pretend to be a pediatric urologist, but a lot of them have these underlying problems like posterior urethral valves and so on, or reflux, vesicoureteral reflux, where the bladder, if you remember the anatomy, when they pass urine, the urine goes from the bladder up to the kidney.
Right.
And these things can cause.
Is holding up your urine a big cause of getting urinary tract infections, or you think it's not a big cause? I
don't have any evidence for that. I advise people not to do it. Because it seems like the right thing to do, but it's not really supported in the literature. Let me put it that way.
All right. Josh, you have any more questions there for the time being? Or comments? All right, cool. So the diet, Doc, tell us a little bit about that again. Sorry.
Yeah. So the best thing you can do is lots and lots of fluids. And the best thing for that is water. So my advice to patients is usually drink enough water to pass about 1.5 to 2 liters of urine.
I think you have a slide on that as well for kidney stones.
Let's pull that slide up.
Yeah.
And you can mix some lemon into the water to make the lemon is good because it alkalinizes the urine.
Right.
Stones tend to form, especially uric acid stones.
In acidic urine?
In acidic urine. And you find that a lot. I mean, you look at a lot of urinalysis.
Yeah.
And pay attention to the pH for your patients. You'll see a lot of those pHs are like 5.
Yeah.
Your urine pH should be around 6.
Yeah.
So in a minute we'll pull up, there we go.
Yeah.
So liquids, less meat.
Yeah.
So protein breaks down in the body, and you can end up with a high rate of uric acid stones. Right. Less salt. This is something people don't know.
Yeah.
So salt and calcium is excreted in the urine at the same time.
Right.
So sodium.
Right.
So the more sodium your body takes in, it's going to want to get rid of some of that sodium.
Right.
So it's going to pass sodium out. You end up passing calcium out at the same time, and you form stones.
Right.
So you want to eat as little salt as you can.
Yeah.
Fresh fruits and vegetables, because it has a substance in it called citrate that helps prevent stone formation. And then lastly is another contentious one. Our primary care colleagues say all the time, stay away from dairy or stay away from calcium, because that's intuitive, right?
Yes.
You have more calcium in your diet, you're going to form more stones.
Yeah.
But that's not so.
Milk and,
correct.
And whatever.
So that's not so. What you want to do is maintain your normal amounts of calcium, both from dairy and non-dairy sources like beans and vegetables and so on.
Right.
So you don't have to stop. I'm not advocating to go there and take calcium supplements, but you don't have to stop eating cheese or drinking milk.
Right.
You can continue doing that, because what we found is that if you stop calcium altogether, you actually end up with more stones.
Right. The body begins to compensate, is it?
The most common type of stone is calcium oxalate.
Yeah.
So calcium usually binds to oxalate in the gut and it excretes.
Right.
If you no longer have the calcium in your diet as much, you end up absorbing too much oxalate. You end up with more stones.
All right.
So maintain normal amounts of dairy. Don't stop eating dairy just because you have kidney stones.
All right. So I just want to tie back kidney stones and urinary tract infections in men a little bit, right? And the obvious question is, what about prostate infections? So is there a link between kidney stones, prostate infections, and urinary tract infections? Are people with urinary tract infections more likely to get prostate infections?
You can get, remember, it's all connected.
Prostatitis is the name for prostate infections.
It's all connected. The reverse might be true.
Right.
People who have chronic prostatitis, they could get ascending infection that goes to a UTI.
Right.
And a UTI could lead to the prostate becoming infected, and it's very hard to clear bacteria from your prostate.
Yeah.
You know, because the antibiotics don't penetrate it as well. There's lots of spaces in the prostate for bacteria to hide.
Right. So it's just basically same sort of treatment, less longer periods of antibiotics. And
So the diagnostic process might be a little bit different.
Yeah.
There are different types of prostatitis, but chronic bacterial prostatitis, where they're getting pain between the legs, they're getting pain in the tummy, they might have fever. When you examine them, the prostate might be tender.
Right.
You know, they're getting some burning when they pass urine.
All right.
That requires a longer course, quite rightly, of antibiotics, so as much as 6 weeks.
All right. So, Satya, I just want to move you forward. We went through UTIs, we went through kidney stones. I just want to talk a little bit about erectile dysfunction. Is that a problem that you see a lot in your clinic, men with erectile dysfunction problems? If you could tell us, what is erectile dysfunction?
So,
because you would think in Trinidad we probably have a large amount of erectile dysfunction problems. If you go to any pharmacy in this country, the first thing you see is erectile dysfunction products before you get to the Panadol, right? So is it a bigger problem in Trinidad and other countries? It's a question I ask a lot of
because of our incidence of non-communicable diseases, diabetes, and high blood pressure and so on, we have a high incidence of erectile dysfunction, right? Again, we don't have as much research, which we're working on, but we anecdotally see a lot of patients with it. And some of it is stigma. Men are ashamed to come in and say they have erectile dysfunction.
Of course.
They're ashamed to admit it. They're ashamed to go to the pharmacy. So erectile dysfunction just simply means the inability to achieve an erection that's enough for intercourse.
Okay.
So you have an erection and you lose it, or you don't get an erection at all.
Right. What do you do for these patients when they come in to see you as a consultant urologist?
So we kind of go through the history with them. We go through how long they've had erectile dysfunction, how bad it is, that's important. Do they just need a little bit of help, or do they need a lot of help? And, you know, this is how you get an erection. You know, you have basically, the penis works like hydraulics. There are these two bodies in the penis. It's not a bone. There are these two bodies in the penis, and they become engorged with blood. And, you know, it depends on the blood flow and it depends on the nerves. And if anything goes wrong with either the blood flow or the nerves, or the signals from the brain telling you it's time to get an erection, you have problems with ED. So when we see these guys, we're looking at all these things to find out, you know, what's the cause? Do they have diabetes? We go through the history thoroughly. Are they on any medication that might prevent them from getting erection? Are they on have they had surgery that might, like prostatectomy or something that might prevent it? And, you know, we take a detailed history from them, and then we send them off a blood test. I have a panel of bloods usually send off men for testosterone, the lipid function, is the cholesterol too high that it clogs up the arteries to the penis? And, you know, we send them for kidney function test, thyroid function test. If these are all okay, if we find something, we treat it. If these are all okay, then we prescribe them something to treat the erections. We start with tablets. And of course, lifestyle changes. If a man is overweight and his cholesterol is high and so on, you might recommend exercise, weight loss, and you'll be surprised how much it helps.
So simple lifestyle interventions will help with the quality of erections.
Yeah. But it's not a quick fix. I mean, that requires investment of time and,
Of course. Is there any... all right, yeah, no problem. We just have a question there, Sati. We'll take it before we continue on.
Absolutely.
All right, Josh, you could put on the question there. All right.
Okay, so this looks like somebody's CT scan.
They just asked for advice.
Yeah. So the right kidney is normal. The left kidney is non-obstructing, just means it's not blocking. 1.6 centimeter by 0.9 centimeters of the kidney. We talk about upper pole, mid pole, and lower pole. So, you know what kidney looks like. We saw the anatomy. So this is stuck at the top of the kidney there. It's not blocking the kidney, so that's good. It's 1.6 centimeters. So this patient would actually be suitable for laser or PCNL. 1.6 centimeters is a stone that we can laser.
All right, so I think...
But you will need intervention for that.
Sorry?
They will need intervention. They're not going to pass that stone.
So, viewer, which is really some big general advice there, that result should really be taken back to their doctor.
Absolutely.
And their urologist, because there's more to treating a patient than just watching a result.
Correct. I mean, you have to look at that patient now and find out what comorbidities they have, what's wrong with them,
exactly.
What's their body habitus like, what do they want, you know?
Exactly. So there's a lot more to it than just watching the result and deciding what the patient wants. However, you have put forward based on what they're seeing there, what suitable treatment for a stone of that size, and that
all things considered, ureteroscopy or PCNL would be the treatment for those for that stone.
All right, that's fine. So viewer, I hope that helps you, the viewer. So what other treatments we would have for patients with erectile dysfunction?
So we start with tablets, right? And there are a number of different types. I mean, there's a drug called the PD5 class, right? So basically, when you get an erection, these chemicals are responsible for taking things back to normal. We prevent those chemicals from degrading. So we keep those chemicals in the body with these tablets. So that's what Viagra does. That's what Cialis does. What Levitra does. Once we move on from that, if that's not working, there are different options. Locally, we have the injections, and I know this sounds terrifying, but it's not. It's a tiny little needle, and they can put into the penis like is shown here. And viewers, please don't be discouraged. This is, people do this all the time. It looks worse than it actually is.
If anyone has any questions, now is the best time to put them into Dr. Saty, because we have about 10 more minutes left, I think.
Yeah.
So go ahead.
So we inject the penis, and the patient does this at home.
Right.
And they get a good erection from this sometimes.
What do you inject it with?
It's a chemical. It has. We have trimix in Trinidad. So it's a mixture of 3 chemicals, and it's stronger than, if you want to think of it that way, than the Viagra. It's directly into the penis, and it bypasses the nerves essentially.
Right.
So it just increases blood flow.
All right. Any other treatments besides those?
So soon we're actually hoping so there's vacuum therapy, which is, patients don't like it because, basically it involves, I don't have a slide of it, but it involves putting a vacuum over the penis and pumping it up and then putting a ring. It can be difficult because it can cause the ring can get tight and the penis feels cold and unnatural.
All right. So Josh, we have any more questions there coming in? No?
And the final thing, if you reach that stage, we're looking at a prosthesis. So this replaces the normal hydraulics of the penis with an artificial.
All right, Saty, we're going to take a question, right? And after the question, I want you to discuss a little bit about testosterone in men, in older men. So, Josh, you could take put up the question there. If left untreated, how bad can it get with kidney stones?
So, if left untreated, kidney stones can, even a stone that's blocking. So, for instance, this last patient with the 1.6 centimeter stone. If we leave that untreated, there's a chance that can fall down from the upper pole because of gravity, and it blocks. And then you can get kidney damage. If the stone stays there for a few weeks, blocking the kidney, you can get kidney damage. If it stays there, I had a patient the other day living there with a stone for 6 months. And her ureter insides looks horrible when you do the ureteroscopy because it causes a lot of scarring. And you can get an infection. You could potentially lose a kidney if you leave kidney stones untreated.
All right, cool. Josh, you put up our next question there. How often do you have to take the injection for ED, and how often would an individual have to do this?
So it's every time you want to have an erection.
Good question.
Yeah, it's every time you want to have an erection. For most men, it's a few times a week. But I don't advocate taking it multiple times for the day. Okay, but every time you want to have an erection, and those really depend. So I usually do the first injection for patients just to kind of find a dose. So I start off at an empirical dose, so a dose for everybody, 0.3 cc's.
And then you scale it up.
And then we scale it up depending on the response.
Right.
And it's actually quite safe.
Good.
You just have to be careful how you inject it. You're not injecting it under the skin, but all these things will be discussed with your urologist once you talk to them. They'll show you how to put it in.
All right. Saty, what's your role of testosterone in ED on older patients or older men? It's quite big in the United States. A lot of patients who come back, they're taking testosterone prescribed by their doctor. Can you tell us a little bit about it? Bear in mind, we only have about 5 more minutes for the program, but if you could just give us a little brief description of when would a patient need testosterone replacement?
So testosterone is very important, right? It's not just for sexual development. I mean, it's your whole well-being. A man who doesn't have testosterone is going to feel tired and listless. He's going to feel down all the time, depressed. He's going to have erectile dysfunction. He might lose muscle mass. So
what age group is this, man?
So we have a thing called androgen decline in the age of male. So you're talking about men going up into the 50s, right? Sometimes even in the 40s. And testosterone declines slowly with age. So for some men, they end up having a low testosterone. And it can be very troublesome because they have erectile dysfunction. They're getting a lot of flack from their partners because it's causing a relationship issue. They don't feel like going to work. They don't feel like they have anything to live for.
A little depression too.
Depression, absolutely. And they're ashamed to come forward because they don't know what's wrong. So they might come for the erectile dysfunction. So I encourage you to come forward if you have all these symptoms because it's something that we can treat. And there are a lot of options. I mean, unfortunately, not as many options as I would like locally. The big one that we have locally is the injection, which is actually testosterone injection, which is every 3 months. But you know, there are other options if you can get it, where there's intranasal testosterone gel, testosterone deodorant. And just one final comment on testosterone: the young male with low testosterone and infertility. I see this too many times, right? The response, so they have a low sperm count.
Yes.
The sperm count might be about 10 million per mil or something, or 5 million.
Which is low.
And the knee-jerk reflex is to give them oral testosterone, or to give them testosterone injections to raise the testosterone, see if that will help. What that actually does is drop your sperm count even further.
This is very important. I actually see this in my clinic too as well.
So if you don't know, now to know, right? We see GP colleagues of yours and mine doing this. And even urologists, one or two of them, giving in these injections and it drops the testosterone. That's not the way to treat that, right?
Or oral testosterone.
Yeah, oral testosterone, because it shuts off your normal production. So while it might raise your testosterone, it's not going to do anything for your sperm count.
Right, but it's at least, is it safe in the older patients, testosterone?
It is safe, but I mean, there are precautions. I mean, you have to check the liver function test. You have to make sure the PSA, they don't have prostate cancer. Although that's a controversial topic. You have to make sure you do the blood count to make sure that the blood count is not too high.
Okay.
All right, so all these precautions you have to take. So urologist usually goes through that. We go through a checklist, make sure it's safe.
All right. Sati, we've come to the end of the program. It's been a very entertaining and educational hour. We touched on 3 major topics in urology. You presented the material very well, and you explained it in a very simple way that all of us would have understood. And I just want to thank you for that.
I'm happy to help. I mean, patient education is key.
Yes.
You know, you can't take advantage of a patient if they know what they're doing.
Exactly. Education and everything is the key. We build knowledge and we don't exploit ignorance. And if we do that, things get better for everyone. All right, guys. So I'd just like to say thank you again to Dr. Satyendra Persaud. He gave us a good night's education. And I'd just like to thank all you viewers who sent in messages. I'd just like to thank Josh for helping us produce this show tonight. And I'd just like to wish each and every one of you a pleasant good evening. So take care, guys. We'll see you again next week. God bless. Keep safe. Good night, everyone.